So this morning, I'm very privileged to welcome my colleague and friend, Ruth Farrell. We are partners in crime on the CTSC here at Case Western and all of our affiliate hospitals, including Cleveland Clinic, where Ruth is based, University Hospitals, Metro Health, the VA, et cetera. And she is going to talk to us this morning. Ruth is a obstetrician gynecologist with a very strong research background in translational research, and very especially interested in non-invasive prenatal testing, ethical frameworks that apply to that, as well as new developments. And of course, this is highly aligned with the purpose of the UH Advanced Center to improve diagnosis, because we are all about best practices. And I myself am not too familiar with, I see a prenatal patient once or twice a month, and I kind of have to scramble and figure it out. But then I forget, of course, what I was supposed to do, which is fairly common, I think. So welcome, Ruth. Thanks again for joining us.
Yeah, thank you.
So we're going to talk in general about non-invasive prenatal testing, but I want to start with cell-free DNA testing and what the general recommendations are. When is it done? How is it done? And what is it designed to detect? Just for everyone's baseline information.
Yeah. And what I'm going to do is, again, thanks for giving me the chance to meet with you all this morning. And what I want to do is talk from the perspective of sort of the primary OB provider. So I'm an OBGYN. I'm not a maternal fetal medicine specialist. I'm not a genetic counselor, but my work really focuses on most patients will see a primary OB, an internal medicine family practice doc who does OB, a nurse practitioner. And so I really want to sort of bring it from that frame, how the most common patient will see sort of the test in that context. So cell-free DNA is a quite interesting test that came out probably about 10 years ago. It's done on, it's a screening test. So it just gives you that risk of a potential fetal chromosomal abnormality. It's not diagnostic. Can be done as early as 9 weeks, but around 10 weeks as well. And that's usually just around where most patients, if they have access to prenatal care in the first trimester, if they know that they're pregnant, they'll come in. Of course, we'll talk more about ethical issues in the end. It's one of the things you wanted me to speak of, and we'll talk about sort of when you can access that. But it can be done all the way up to term, and it can be done for different reasons. And it is done through a maternal blood draw, much like the other screening tests that have been around for decades, such as the quadruple screen, the sequential screen. The cell-free DNA, or also called NIPT or non-invasive prenatal testing, looks for the most common chromosomal aneuploidies, trisomy 18, trisomy 13, and trisomy 21. And the conventional screens that have been in our field have really focused on 3 because they're the most common of the autosomal aneuploidies that we'll see come to birth. So that's why it's been focused on that. But cell-free DNA can also look for a series of other conditions as well. It can look for sex chromosome aneuploidies because it can identify the sex chromosome. So not only give you information about the sex of the fetus, but it'll give you some information about Klinefelter-Turner conditions such as that. And because it's molecularly based, it's got this huge potential to potentially provide information about other conditions. And so it has been used in some contexts for sort of genome-wide screening, though that's quite controversial. It's not the standard of care. Our American College of OBGYN doesn't recommend it in that application, but it has been developed in that way because it's got that molecular base, which allows you to keep sort of expanding. One of the unique advantages to cell-free DNA is that it's got a higher detection rate than any of the conventional screens. So the conventional screens are something like the quadruple screen or the triple screen, or what we call the sequential screen, when we do one part in the first trimester and one part in the second. And those are all great screening tests that give us those risk of these aneuploidies, but they have a false positive rate of about 5%. Now, in medicine, when we think about 5%, based upon our perspectives, that could be a low percent or a high percent. But the fact is, if a test comes back positive, it may lead to a cascade of other complex decisions about diagnostic testing, no further testing, and that can sort of lead to important conversations for patients and for healthcare providers and their patients. So that's a quick overview of it. What other questions can I answer for you about it?
Thank you, Ruth. That was really helpful. I'm just wondering, I mean, is this sort of genome-wide assessment that you suggested, is that even available to women right now?
Well, it is available. So one of the interesting caveats with cell-free DNA is that it's really in the market arena. So commercial laboratories who are advertising directly to patients. So you may have seen some of these ads around. Oftentimes sort of the marketing pitch is really to find out about the sex of your baby. But there's also another marketing pitch where we can hear about sort of dozens of other potential conditions. So the technology exists, and we see this in other contexts of medicine. The technology exists, but should we use it? And how do we work around it when there are a lot of marketing forces sort of encouraging that directly to patients, when there's not a lot of clinical validity about how to use it?
Right.
As we know with a screening test, how we interpret it is based upon sort of how many people in the population may have that condition, right? So we know how to interpret the results. But some of these variants and these different conditions are rare, and so we really don't have that clinical validity. So if you get a result that's positive, what does it mean? How do you interpret it? And in pregnancy, most importantly, is what do you do next?
Right, right. Okay. Well, we'll get back to some of the ethical implications, as you said, but let's just maybe briefly talk about prenatal ultrasound and its current role, given the availability of cell-free DNA, and how and when would we use it?
Yeah, so all of the screening tests work together to help determine anything you can find out about the fetus without trying to go to diagnostic testing. Now, diagnostic testing, I'm going to go there briefly. That includes chorionic villus sampling, CVS, and amniocentesis. And these are very safe procedures. I don't want to sort of mislead anyone with that. Though they are invasive, so it requires inserting a needle inside the uterus and either collecting placental cells or fluid around the fetus. And there are risks with that. One is it's a procedure. There's a risk of infection. There's a risk of miscarriage. So while it's rare, it used to be higher, those exist. And it's also how some women may think about the procedures, patients may think about procedures during pregnancy. So there's a cohort of different screening tests to try and get as much information as possible before you need to get to that point. The ultrasound is important because the cell-free DNA and the screening tests that we have will only tell you about a small cohort of potential conditions, but it's not all. And there are several anatomical findings as well that either may sort of give more information about those conditions or other conditions which these tests don't pick up at all. So ultrasound is still very important, but we do consider it a screening test most often, and we use it in conjunction with other screening tests. So one option is called nuchal translucency. It's done in the first trimester. It can be used in conjunction with these screening tests to give more accuracy. And it looks at the space on the back of the fetal neck, and that helps determine some risk of aneuploidy. But you can also pick up other conditions at the same time, other soft markers, so to speak, as we call them. And then the second ultrasound is usually done in the second trimester. That's sort of the main anatomical screening. And that'll sort of give you that scan and look for a variety of different, either known chromosomal soft markers, sort of more diagnostic markers, or just any other fetal abnormality. So we use them in conjunction to help get as much information as possible prior to birth, or to help inform the decision if you want to do diagnostic testing.
Okay, terrific. So, I mean, you mentioned cell-free DNA has been around for 10 years, and we still haven't got to the ethical implications of it. What can you highlight besides that, some of the developments that are either related to cell-free DNA or otherwise related to non-invasive prenatal testing that are promising in terms of overall well-being of mother and child?
So other promising applications are still really in the works, and anything I'll mention now is not recommended for general use. And sort of our American College of OBGYN gives us a lot of guidance about sort of how to use these. And so primarily it's recommended, for those 3 autosomal aneuploidies, trisomy 18, 13, and 21, and some of the sex chromosomes. So all the other applications are yet questionable. There are a series of other microdeletions that potentially could be picked up with the cell-free DNA, but again, it's a screening test, so you still have to go forth and sort of get more diagnostic tests. There's also the potential for single gene disorders. So again, this is not prime time, and ACOG actually recommends that it's not ready for prime time, but using something like cell-free DNA to look for the risk of skeletal dysplasias, sickle cell, and cystic fibrosis. So that would be really important as well, because these represent important conditions. They also represent carrier screening opportunities. So before people get pregnant or in early pregnancy, but they're often missed. So it's a way to come back and try and identify any risks if some earlier screening options haven't been brought to fruition.
Okay, thank you. So let's move on to your own work, and I think we'll talk about ethical frameworks in that context. You're the PI of an R01 project designed to provide patients with a better understanding of non-invasive prenatal testing options and results. Can you tell us a bit more about that project that's underway right now?
Yeah, and in that I'll weave the ethical issues that go along with the test. And it would be great if we could have a clean conversation. Let's talk about the medical aspects and let's talk about the ethical, legal, and social aspects, but we can't, particularly when it comes to things like prenatal testing and pregnancy, especially given light all sort of the news of recently with respect to sort of reproductive care.
Yeah.
The interesting thing about my work is that many years ago, I was a KL2 scholar with the CTSC, and that was back in 2007. And my question at that time was, how can we ensure that pregnant patients can make informed decisions about their prenatal genetic testing options? That includes the screening options and the diagnostic testing options. Now, at that point in time, the new test was this first trimester screen. It was part of that, what we use now, sequential. Before that, the only screening you could really do was in the second trimester. That was the old quadruple screen or triple screen. And back in the early 2000s, a new test called the first trimester screen really moved the timeline from the second trimester to the first trimester for patients to find out about aneuploidy. That was significant because timing is everything in pregnancy. Every week, every day can make a huge difference with respect to what the options are. So when I started my research, the first trimester screen was sort of the new test. And my challenge was, how do we help patients understand not just sort of what we're looking for with conditions, but if we move that information to the first trimester, where it gives patients more options, but also there's a higher risk of miscarriage in the first trimester, just naturally.
Sure. Yeah.
How do we help patients understand this? So the interesting thing with cell-free DNA is that my question from my KL2, more than 10 years ago, is the same. How do we ensure patients make informed decisions about their prenatal genetic testing options? And the technology has continued to change along the way. So now my work focuses on cell-free DNA. So I think it's interesting because for years in our field, technology is pushed faster than we always know how to either understand it or integrate it into patient care in a way that patients can understand it.
So
So
what are some of the challenges in helping patients to understand? Is it risk assessment? Is that their main challenge, or how do you set up a framework for comprehension of this information?
Right. So if we want to sort of focus on an informed decision-making and shared decision-making model, part of this is understanding what the conditions are that can be detected. So talking about trisomy 21, sort of what it is and what the outcomes are. 13, 18, talking about the different conditions. Then it's talking about the different tests. What kind of information do you want and value? And I'm going to come back to this word to value and preferences, because that's what's a driver here. Do you want screening information, probability information, which is not diagnostic, but there's no procedural risk, there's no risk of miscarriage, there's no invasive procedures. Do you want that kind of information? Or do you want definitive diagnostic information? So it's knowing sort of what the different options are, because truly we offer patients both options equally, sort of in equipoise fashion. The fact is, patients, if they desire diagnostic testing, should be able to have it from the get-go. It shouldn't have to be a secondary round of tests. And then if someone wants sort of that screening information, we have to talk about probabilities. Now, we all know on this call, whether we're in obstetrics or not, the challenge as it comes to talking about patients with probability, right? Understanding our health literacy and understanding, percentage versus probability, rates, odds ratios, trying to understand that overall. But then when we think about sort of the informed decision-making for prenatal testing, understand that in the context of this pregnancy and this set of values and preferences. Because so much of this decision, all decisions in medicine involve our preferences and values, but this one is particularly sensitive to it because it depends, what am I going to find out about the fetus, my future child? What am I going to do about it? Will I do more testing and potentially take risks for miscarriage or complications? Will I end the pregnancy? What will I do next? If there's a child who may have a serious condition, will I parent that child? Will I look for adoptive parents to parent that child? What will I do? Do I have the resources for that? So it's a complex decision. The medical facts, yeah, we can explain those. But when you get into that probability and risk, and understanding how that applies to an individual and their values about disability, parenting, children, abortion, it gets very difficult.
Absolutely. Yeah, thank you for that. So let's talk a little bit about the future of non-invasive prenatal testing. Where are we headed, not just in terms of new diagnostic tools, but you mentioned ACOG taking some firm positions as to some issues, but where are we also headed in terms of ethical and social implications and policy issues?
Yeah, a few years ago, we could have had conversations about prenatal genetic testing, just talking about the tests themselves and the conditions.
Mm-hmm.
But we recognize we have to sort of expand that landscape. And so when we talk about the complexity of decision making and where we go, it's not just sort of what tests we can do. And so when you just think about the genetic tests, the screening tests, it's pretty remarkable how much more we can find out. And so I think in the future, fine tuning to understand if we can identify genome-wide, deletions, abnormalities, what do they mean? So that'll be sort of part of the technology. It's also hand in hand with things such as microarray. So now if you're doing diagnostic testing and you can get information about a series of other genetic conditions, again, how do you interpret that and make clinical decisions about it? Now I'm going to go to those clinical decisions for a second, because our future isn't just sort of what genetic technology is developed and implemented, but also how it's marketed. Who has the patent for it? Who are the commercial laboratories? What are they trying to sell for patients and providers? But we also have to think about this changing landscape outside of testing. So there are advances in maternal fetal medicine and these maternal fetal procedures that can't reverse a genetic condition, but can certainly help mitigate some of the downstream anatomical complications that can happen. And so the variety, either maternal fetal interventions, surgeries, different procedures that can now be done to try and improve outcomes at the time of birth. So that field is expanding. So when we think about if my future child may have a genetic condition, before I really couldn't do anything about it. I'd either end the pregnancy or continue planning. But there may be something now I can do with the maternal fetal and the pediatric surgeons. So that's also how we have to context what's happening in the testing. But it's also advances in neonatal and pediatric medicine as well. What can be done sort of right at birth to help support and mitigate and optimize outcomes is important as well. So these are fields in parallel that are advancing. But we also need to talk about the Dobbs decision and access to termination. Not all patients who do prenatal testing do it to terminate a pregnancy. Many do it to access information they can prepare.
Sure.
But there are some patients who decide based upon the severity of the condition to end the pregnancy. But that's becoming increasingly more difficult. So we need to sort of broaden our focus when we talk about these tests. It'd be great if we could just talk about the technology and how it's advancing within the tests. That's pretty remarkable as is.
Mm-hmm.
But then we have to put in that context of what we all face on this call. When you have a test result, what do you do about it? If it's a screen result, how do you walk your patient through risk and probability and next steps? It's common among all of us, even if we don't do obstetrics or deal with this test on a daily basis.
Well, yeah, it sounds like at a prenatal visit where you're going to discuss non-invasive prenatal testing, that would be the whole visit, basically. You've got so many things to talk about, not just the testing, the conditions, but what considerations should be thought about in terms of if the result is positive or negative. So much more information than there used to be. That's for sure. Okay.
That's a great point. Can I add to that for a quick second?
Absolutely. Yeah.
So with our R01, we were looking at the impact of a point of care shared decision-making tool at the very onset of care. So we could really anchor patients' thinking about sort of what they may hear about in the visit. And we're hoping to sort of improve informed decision-making. As part of that, we did a direct observation of the prenatal visit. So we actually put a audio recorder in the room. And so we wanted to record those discussions so then we can look and see what people are talking about. When you talk about how much time you have, those conversations on average in a 30-minute visit are about 4 minutes. So in 4 minutes, you have to talk about all the genetic conditions, your different testing, screening, diagnostic options. You got to mention a little about risk and probability and talk about an individual's baseline risk. We talk about maternal age or reproductive history as sort of indicating risk for these tests and how you interpret it. So you've got about 4 or 5 minutes these days to talk about that. But the trick is for some patients, again, based upon when they start prenatal care, that first visit may be the only touch they have with a healthcare provider before they make the choice to start testing or decline testing.
Right.
And so how do we level set that? So again, if you have a patient who doesn't have access to healthcare and doesn't get in until the second trimester, how do you then ensure that that individual has all the access they need if they don't have time to see a maternal fetal medicine specialist or genetic counselor? As they walk out the door, it's the last time you'll see them, and they'll choose in that space between when you see them now and next time.
Wow.
Am I going to do this or not do this? So it raises a good question. If we have 4 to 5 minutes, how do we use that time? Because that's also been more complicated by COVID, right? So now pregnant patients had to ask about COVID and COVID vaccination, but the visit time, as we all know, is not expanding. We don't get more time.
No, and I think there's issues of health equity as well. I can imagine highly educated women really, even within 4 or 5 minutes, really getting a good picture of what choices that are available to them and what the options are. But others, especially those with low health literacy, low numeracy in particular, are really going to struggle and won't be able to take advantage of the information in the same way. So that's a major issue.
It also affects how you're coming in as a patient and your headspace to that first visit. So some patients may have had no complications, and so they're ready to move on with their care. Some patients may have had spotting or bleeding, been sort of worked up for miscarriage, and so they may not even know if this pregnancy is going to come to fruition. And that will sort of change how they're thinking about the pregnancy, but also their ability to take in more information, right? It's getting a little overloaded here.
Yeah.
And there could be some patients who didn't know they're pregnant and suddenly found it out, and they don't know if they're going to continue the pregnancy or end the pregnancy, but they're showing up for their first prenatal visit to get some information. So when we sit across from a patient, we never really know when we start out our conversation, where are they in their headspace and what do they want to know about and what do they not want to talk about? You may have some patients who say, I don't want to talk about termination. I don't want to talk about disabilities. I don't want to hear it. And so how do we personalize these intense, potentially complex decisions and conversations as healthcare providers?
Right. Fascinating discussion. Thank you, Ruth. So we have a few minutes left, and we're supposed to throw this open to our group that's joined us this morning. So if there are any questions or comments, now's the time. Please do speak up.
I'm going to change my view so I can see all who's on the call.
Yeah, I'm going to scroll through here as well. Everybody's very quiet.
Would there be any role for like group visits to discuss testing options? That way you could have a more extended discussion. You could have more question and answer. Would that be an option that would be feasible?
Yes, I think group visits are feasible. I think modules that give asynchronous learning are feasible. I think there are lots of opportunities. And I think as healthcare providers, we have to get that information to our patients and try and keep them off the internet. Again, there's a lot of misinformation on the internet, and a lot of commercial laboratories are also directing, marketing to patients. So I think the most we can do as healthcare team members to get that information, accurate, unbiased information about these tests is great. So we can supplement before that first prenatal visit, we can supplement after, but we also have to figure out sort of what is the best way, the best timing, and how to capture those patients and how to support them throughout the pregnancy. Since the first test, the first decision, am I going to do screening or not, is only the very first decision. Once the result comes back, then what do you do? And we know preferences will change with both information obtained, but also the experience of pregnancy. So as now early in first trimester, maybe no family members know, but in second trimester, as things go forward, more people may know what happens with the pregnancy, and it may be more physically visible. So thinking about how do we get that early on and how do we keep it across the longitude of pregnancy?
Okay, Dr. Atchison has a question. Louise, can you unmute, please, before?
Yes, I'm sorry there's not more time because I would love to thank you more profusely for this. But my question has to do with the constraints on people who end a pregnancy after diagnosis of trisomy 21 in particular, and the law that we have in Ohio that says that no one should do an abortion for that reason.
Yeah, so I think it's become very tricky. As we all know in this call, the fact is that there's a lot of support to do tests and to find out information. But once that information is confirmed, what do you do about it and what can you do about it? And so it does bring again this access issue. If you have the ability to go to another state to have a procedure done, that benefits you and what you're trying to achieve. But if you don't, that really shapes what's going on. So when we think about the testing, we have to think about sort of what are the options on the back end if a condition is diagnosed. We're in a very difficult time right now with that. And so we also have to think about healthcare providers. If we're encouraging screen and diagnose and learn, then we also have to support our patients on the back end. We all have to be able to react in the context of a test and help our patients through that. So it's an important question, and we're going to have to see how things change with that.
Thanks for your question, Louise. We'll give you, we have time for one more question, 7:59. So anyone else? Okay. All right. Well, thank you so much, Ruth, for joining us this morning. It was a fascinating discussion. I echo Louise's sentiment, not just the thank you part, but wish we could talk for a few more hours about this, but unfortunately we can't. So next week, we will have a fascinating discussion about diagnosis of type 1 diabetes in children and how, of course, that's been complicated by the obesity epidemic. So please join us for that as well, and have a wonderful day. Thank you.
Thanks, everyone.
Bye-bye.
Bye.